All right, I think we've got everybody in, so I want to welcome everyone to our seminar tonight. It's hosted by the UAB Maternal and Child Health Association, or the MCHSA, and that's a UAB registered student organization on campus. Their members are both undergraduate and graduate students from all across campus. They just have one thing in common for sure, oftentimes more than one, and that one thing is a special interest in maternal and child health. So if you'd like to learn more about the MCHSA, just Google UAB Engage page, and you can add the MCHSA in the search box and get to our Engage page. You can learn more. If you're a student, you can join the organization. And now I'm going to kick it off to the MCHSA President, Chittima. She's going to introduce our speaker tonight.
Thank you, Julie, and hello and welcome to this month's seminar, everyone. It is so great to have you all joining us here this evening. Today's seminar promises to be a really great one. Today we have Dr. Karmie Johnson, who is a doctor of nursing practice here at the University of Alabama at Birmingham School of Nursing. She serves as the assistant professor at the school with a specialization in mental health nursing. And Dr. Johnson has been the lead psychiatric mental health nurse practitioner. That's that long acronym at the end of her name there. I just learned that. And she oversees several nurse-led clinics serving low-income adults with chronic disease and has been doing so since 2013. And in 2018, she became the lead nurse practitioner and coordinator of mental health and wellness for the Nurse Family Partnership of Greater Alabama. This evening, Dr. Karmie Johnson joins us to discuss some more about herself, her background, her work, with a special emphasis on the management of perinatal mood and anxiety disorders. And without further ado, Dr. Johnson, take it away.
Thank you so much for that warm introduction. So this kind of presentation, I went kind of clinician heavy focused initially, but I am open to sort of talking about the breadth of what I do and welcome questions definitely at the end. So I'll leave more time than I usually would for that. So that we can have more of a discussion maybe about what I do and some other things that could interest you guys within perinatal mood and anxiety disorders. So, but I'll go ahead and get started with this PowerPoint about specifically kind of the usual protocols for the management of mood and anxiety disorders that pop up during that perinatal period. So within this, let's see. Here we are. I always had to have a couple of learning objectives. I wouldn't be in education if I didn't. But again, by the end of this, I'm hoping that you can talk a little bit more about these mood and anxiety disorders, the effect, the impact on mothers, on infants, on families, some of the recommended screening tools that I use that people might see in order to gauge if we need to do further referral pathways. Also, some of the treatments, first line treatments, both psychotherapy, which is just a fun word for just therapies, the talking, and then also pharmacotherapies, which is a big word for the medications that might be used. Some also the safety considerations we'd use with the medications, both during pregnancy and in breastfeeding. Also, some red flags about one particular symptom or symptomology that we do kind of worry about more than others that needs an acute approach, an immediate approach. And then also some practical management tools that I've used in my role as a psych NP that for the last 7 years has worked primarily with moms. So without further ado, we're going to launch into this. So what are the PMADs? So the perinatal mood disorders. And it's funny because we used to call them, like everyone has heard, or you used to probably hear more about postpartum depression. That was the big one. Well, we changed the terminology a few years ago, and we'll go into why. But we look at those things not just as depression, but across mood disorders. And when I always think of mood is kind of the way you are feeling. I think of mood as the highs and the lows. My low mood, we tend to think of depression. Within that, though, too, there's some higher ones that we would look at bipolar, some mania, that kind of quality of being too elated. We tend not to see that pop up, first onset during pregnancy or related to or caused by pregnancy, though things like bipolar can happen at any time. I would look at that more as something that was happening pre-pregnancy. Though there is a body of literature that is emerging that pregnancy can be the first onset of that. But we're kind of going to focus more on that depression, anxiety disorders that can pop up related to pregnancy, postnatal anxiety, generalized anxiety disorder, OCD, PTSD. So that OCD that people, here we are. So what are these things? Again, those mood disorders, again, the high highs, the low lows, anxiety disorders. It's funny, we used to think you'd hear about postpartum depression. You rarely heard about postpartum anxiety or perinatal anxiety. And that's what I see a ton of. I'm going to talk about kind of what that looks like versus normal anxiety. Psychosis, postpartum psychosis. We'll talk about what that is. All these things kind of fall within this DSM-5 TR. The DSM, if you're unfamiliar with it, it is kind of the Bible of psychiatric disorders. I always say that the medical model says that if I think someone has diabetes, I run them through some labs, I do certain things, and they'll hit certain parameters. How do we know what happens with people mental health wise? People think that we just, that it used to be that, oh, they just made this up. That's not true at all. We have a diagnostic manual. People have to hit certain criteria for us to be able to diagnose them. So we're not doing this kind of willy-nilly. But within that, a disorder, and I always say this to my students, disorders have to impede functionality. There's a big difference between sadness and depression. Depression has a functional quality to it. People get sad all the time. I get sad because I watch a sad movie, but I bounce back from that, right? That's a normal fluctuation in my emotions. Mood, if it stays down like that, that's depression, and that can look like it's going to really impede how you function across several domains, and it also has a certain time period to it. Within these disorders, we also look at what we call comorbidities. Are there other things, other diagnoses that are kind of blurring the waters of this? Substance abuse. Depending on the substance, we have things like alcohol, which brings our mood down. So if you're having alcohol, alcohol is a natural depressant. So someone says, oh, I'm so depressed, but I'm like, but you're drinking. I don't know if that's your normal mood, which could be treated different ways, or if that's because of the alcohol. Same thing with someone saying, oh, I think I have bipolar. I'm manic and I stay up 3 days in a row. But then I find out you've been doing cocaine for 3 days. And I'm like, well, that's not a true psychiatric disorder. So we would look at things like that. That's a comorbidity. Sleep disturbances. Pregnancy, I've had people like they just can't get comfortable while pregnant. You've got a basketball you're trying to sleep on. And then afterwards too, you're worried about the child. You're coming down from a hormone just dump. All those sleep disturbances that we would consider when looking at what's going on. The other thing is history of trauma. Having done this work for a number of years, I really do. I think that isolation goes undiagnosed as a factor in contributing to people's mental health. The other one is history of trauma. I'm just like, is this that or is this PTSD? We look at though, when's the onset? If we say perinatal, what we say is, did this stuff start during pregnancy or within 12 weeks postpartum? So about 3 months. We've extended that, and I believe in extending that. I believe that we say, oh, just postpartum is that 3-month period. I'm like, no, we probably need to extend it to a year. Because what can happen in 3 months is we talk about fight or flight, or we talk about the newness of this baby, or we talk about their supports around for that time period. When that support, when the newness wears off, maybe at the 4-month mark, that whole time we've been furiously hiding that. Do you know, like we've just been working really hard. We haven't noticed. All of a sudden then we notice, I have not been feeling well this whole time, but then they're out of the 3-month mark. So I'm a big fan of extending that to a full year because of the changes that can happen, not just to the mom, to the family structure with parenting, all those things. But that's where we changed it from postpartum, which is kind of post-delivery, to perinatal, which is across the entirety of the pregnancy experience. Let's see. Is that advancing correctly for you guys? I just want to double check. Let me see it up in the chat. If you're just like, yep,
Yes.
perfect, great. So Within this perinatal depression, we changed it from postpartum depression to perinatal depression, which I'm a fan of, again, because what I've seen is it's not like, oh, I just got depressed after I gave birth. What we see, if we can do good screeners, if we can do good interviews, you've been feeling this way for a lot longer. You've been feeling this way starting in pregnancy. So some common symptoms with that depression: persistent low mood, persistent sadness, loss of interest or pleasure. The things that used to make you happy or used to enjoy, you just can't get that joy back. Fatigue, insomnia, or hypersomnia. That means like sleeping all the time or not sleeping enough. What I will say, here's one of the fun things I always think. People say, and when I ask, I'm like, how have you been sleeping? Someone will say, I slept 16 hours. But I ask, were you really sleeping? Or how was the quality of your sleep? You may have been in bed for 16 hours, but you only got 4 good hours of sleep. So that's something to consider. So it will generally be an altered sleep pattern. Appetite changes. Some people eat their feelings, but most people, honestly, don't have an appetite. Even if they're eating, they're not really tasting the food. There's no pleasure in it. They're just eating to eat. Excessive guilt, excessive hopelessness, concentration problems. And those concentration problems can make it so that the indecisiveness, I just don't know what to do next. That's the concentration part that we see oftentimes in depression. It's not, the ADHD concentration part. It's I can't pull enough information together to make a decision. Difficulty bonding with the infant. That's what we'll see within, the perinatal. Withdrawal from supports. Again, pulling back from people that have been supportive, not going out with friends as much, just isolating more. This can co-occur a lot with anxiety. I've said it for years, anxiety and depression to me are two sides of the same coin. The things that make us depressed often make us anxious, right? Like we get anxious then about our depression and vice versa. We're so anxious sometimes that we just throw our hands up and think there's nothing we can do. And so those often to me walk hand in hand, though they can be very distinct diagnostic criteria, very distinct symptomologies. But I do see a good bit of overlap with those sometimes, especially the longer it goes untreated. We can also have panic within these things and intrusive thoughts. Intrusive thoughts are those thoughts that come out of nowhere and you don't know where they came from and you don't like them. You acknowledge, you're like, I don't know why I wanted to do that thing. That makes no sense. That then begins to worry people. We look at the difference between perinatal depression and baby blues. Baby blues are kind of mild short-term changes right after childbirth. I've always thought of it as you've had this great kind of hormonal surge, and now you've got this hormonal dump. That is the body readjusting to that. That is a pretty typical thing. It can be mild mood changes, short-term ones, typically starts a few days after giving birth, should resolve in about 1 to 2 weeks. You don't really need medical treatment for it. Some common symptoms are those mood swings. Again, the hormones. They went from up to down and they're trying to get back on board. Irritability, tearfulness, feeling overwhelmed, like anxious, fatigue, insomnia, heightened emotional sensitivity. That you usually just, I want to say you write it out, but what I always want to know is this happening? Because sometimes it can lead to perinatal depression. So I want to normalize baby blues and talking about them, but also want to have a follow-up. Be like, okay, instead of being like, well, that's just baby blues and dismissing it, be like, oh, that is a typical thing, but let's stay ahead of it. If this doesn't go away within 2 weeks, or if you feel that it is so overwhelming, it's affecting you, there's some other things that we can look at too. I as much as I like a diagnostic criteria, I'm prefer helping people. So what's more important to me than the diagnosis is resources I might give somebody and normalizing the way that they are feeling. So within this, the prevalence, and here's why, again, we changed it. Postpartum depression, perinatal depression, 10 to 20% globally. Again, anxiety, very common within it. What we saw was 27% had an onset of this episode before pregnancy. So again, there was symptoms of this before they ever were pregnant. 33% had some symptoms during pregnancies when they first popped up. Only about 40% had episodes that began in the postpartum period. So a full 60% were having symptoms of depression before they ever had that baby, right? So why are we waiting till the after you have the baby period to begin treating, to begin looking at how to manage these feelings? I always think I was like, that's such a mistake to do that. So that was, again, I'm a pro changing that term from postpartum to perinatal. That perinatal anxiety. Here's the one again. I don't see it get diagnosed enough, but I see it in practice a ton, a ton. It's excessive worry or anxiety occurring during pregnancy or up to 12 months in that postpartum period. That would include generalized anxiety disorder. That's what GAD is, just that constant excessive worry. And the thing about that anxiety is you often don't know where it comes from. And not knowing where it comes from turns around and makes you more anxious. Panic disorders, panic attacks tend to have a different flavor. They have a body quality. You'll see, I'll often ask my patients, like my clients, like, what does panic look like for you? Often heart racing. It shows up in the body, again, sweaty palms, just that feeling of impending doom. It often, again, has a body quality to panic. OCD. You guys maybe have heard of OCD. I often think that people get the wrong, they think that, people are like, oh, I like to color code my closet, so I'm OCD. And I'm like, that is not the diagnostic criteria of OCD. OCD is obsessions. Again, those intrusive thoughts that come into your head and you don't know why they're there. And the compulsions, you then develop little coping things to make those obsessions quiet down. Things like, I am obsessed with germs. But if I wash my hands 27 times in a row, I'll have handled the germs. That's that compulsion that calms the anxiety related to that obsession that really doesn't make sense. So there are a lot of checking behaviors. We see that again, not related to pregnancy. Not related to pregnancy, it's something that I want to help someone get treated for. But in pregnancy or post-pregnancy, we tend to dismiss that. I always think, so if somebody was worried about their stove being on and catching fire so that they woke up every 30 minutes to turn the knob to off 14 times before they could lay down and go back to sleep, you'd be worried about them. But if it's a mom waking up every 30 minutes to count 14 breaths of her child, you think that's normal. And they're like, yeah. And I'm like, nope, I don't, not that it's not normal. I'm like, she shouldn't have to suffer that way. She shouldn't have to suffer and think that like this will just go away. There are treatment protocols. There are things that can be done. I don't believe in anyone just getting through it on their own when there are things that we can do to help. Health and anxiety about the infant is another one. The prevalence, again, pretty high, 10 to 25% of people, birthing people, this can occur with, this anxiety. I see a lot more of it than people realize. Common symptoms, again, that excessive worry about pregnancy, about the baby's health, about being a good parent, especially with my first-time moms. But again, anytime mom. Restlessness, irritability, that muscle tension that, again, shows up in panic. Anxiety shows up in our bodies a lot. Sleep disturbances, concentration problems, fatigue, panic attacks, those intrusive thoughts or images. And, I talked about that with the OCD, avoidance behaviors. Again, when we talk about panic, when we talk about PTSD, like, oh, I need to avoid doing this thing. If I'm having anxiety about driving, I'll try to avoid driving. If you're having anxiety about taking your baby out in public, then you just won't take them anywhere. And I'm like, but you've got to grocery shop. You've got to do these things. What are you doing? So those are the ones that we talk about, the avoidance behaviors in perinatal anxiety. So the impact, again, if untreated, it does. We show this, it shows up in the research, it can impair that mother-infant bonding. If mom is so keyed up, like anxiety, or so depressed that she can't really take care of herself, is she necessarily going to take care of the baby as much? We see that in the extreme, but even if she's like, no, I do everything for my child gets fed, gets this, but that bonding, that feeling, I think babies, that energy, it does pass between. If, and that's one of those things. So we can look at seeing some of those bonding things that happen. If you're not experiencing the joy of this, then is that bonding going to be as strong? Maybe not. Adverse infant development. I think a lot of this stuff leads back to that, to the bonding. Increased healthcare utilization. What I mean is lots more doctor's visits, lots more worry about these things. Trying to use healthcare professionals who aren't treating the true root cause. And the true root cause is, again, some of these mood disorders, some of this anxiety. Protective factors that often people have. What are your social supports? Who's helping you? Like who is there being supportive during this time? We use screeners. Providers should be using screeners to try to figure these things out for people, because people are often afraid to ask. They're often afraid with stigma. How I kind of got into the role that I did with the nurse family partnership, it was jokingly, I don't really like babies. It's been a joke that people are like, well, how are you a maternal mental health specialist when you don't like babies? And I'm just like, well, I mean, it's not that I don't like babies. I don't gush over them the way other people do. So what was actually helpful for me was that other people are love talking about the baby. I like to talk with the mom. I like to be like, I know you love your baby. I know. But let's talk about the things you didn't anticipate with this new role. Doesn't mean you don't love your baby. It just means this is hard. And that's okay to acknowledge it. And so being not overly enamored of babies, I think really was helpful for moms to open up and to seek additional resources. Again, the protective factors if they have access to care. Postpartum psychosis, here's my big one. This is the one. Symptoms include when someone is psychotic. What we're looking at is delusions. Delusions are fixed false beliefs, things that we know kind of aren't true, but that person doesn't realize that. They have a whole quality grandiose delusions, paranoid delusions. Even if you try to rationalize to the person, explain it to them, it is fixed in their head. No, this thing is true. Those are very, very hard to shake on your own. Hallucinations often involve our senses, auditory hallucinations, internal voices, either telling us to do things or just hard to tease through what's going on in my head, the internal versus the external. Those are a big one. Visual hallucinations can come with that. Often with moms, things about, the baby being hurt or these things. Confusion, disorientation, thoughts being very confused, disorganized behavior. When we see psychotic behavior and things with moms in that postpartum period, we worry about that. The risk factors would be a history of bipolar, a history of schizophrenia, sleep deprivation. Sometimes this is not because you have a pre-existing condition or this is the new onset of something. We have seen if you are not sleeping well, psychosis can pop up. If I went 3 days without sleeping, I would look psychotic. But what we need to do is address that. The action plan for that is it really is an emergency evaluation. Doesn't mean your baby's going to get taken away. Doesn't mean that you can't be a great mom, but it probably needs, we need to bring you into the hospital, maybe do some meds for you. And meds is not always first line. It is not first line for me a lot of the times. I think therapies, talk therapy, different ones we'll talk about, are first line for me. But meds are a hugely important component for a lot of people. And for this particular diagnosis, it may be the way to go in the short term. I'll want to bring you probably into the hospital to see if we can get the right meds on board quickly. I also want to see you sleep. I've had moms where I'm just like, what was helpful? Bringing them in for 48 hours and having them sleep. And then they become a new person. They're just like, oh my goodness, I don't know why those thoughts were there. And we don't know why they're there, but we want to acknowledge them and to treat them very, very quickly. So if part of that psychosis is we think that the mother is going to be a risk to herself, a risk to the baby, or a risk to other people, we really do need to do an emergency evaluation, and there may be short-term inpatient treatment. So again, that's going to require pretty rapid psychiatric intervention and sometimes use of antipsychotics. Not forever necessarily, but definitely for the moment. Screening and assessments. I think that every mom should be screened for this stuff, and I'll show you my algorithm, and we should start doing it early. A screener is not a diagnostic criteria. It is just checking using specific questions to see how are you doing. It gives us a number to go off of, and there are criteria for mild, moderate to severe symptoms, and we'll talk about this in a minute. We have these universal screeners. I think everybody should know what they are if you're a provider. I think moms should know what they are. If your providers are not asking you these things in a small way, then you need to bring it up. Then you need to be like, hey, this is the way I'm feeling. That's a hard thing to do. So I would absolutely say providers need to be screening. There are often tools, and you'll see what the slides are. These great screening tools. These should be monitored pretty quickly, follow up often, ask about them, and have a multidisciplinary approach. What I mean is, it's not just meds alone. We're going to ask, we're going to use lots of different resources to try to get people feeling better. I will also consider, as a clinician personally, are there other things that aren't related to the pregnancy that have been uncovered that don't require necessarily psych medications? Thyroid disease, anemia, B folate, all those kinds of things. Like, oh, is this a vitamin thing? And that's why they're so fatigued and look depressed. They don't need an antidepressant, they need a multivitamin. Same thing with sleep. Sleep is my number one thing that I look at in anybody, period. It's the number one thing I think that contributes to poor overall health. Here's some of my screening tools. Again, these are great ones that have been used. The Edinburgh is specifically for depression in pregnancy. The PHQ-9 is for depression, can be used at anybody at any stage of life. The GAD is for anxiety. And then again, brief screeners for psychosis. We would ask again, like if I'm at all suspicious of those things because of the other screeners, we would ask any disorganized thinking, any paranoia, anything like that. I have broken this down in a handy dandy chart if you were a clinician to kind of tell you like, oh, here's the difference between these four, those baby blues, and we've gone through it. That's a quick one. The mild mood swings, usually self-limiting, it kind of goes away on its own, usually not needed treatment. Postpartum depression can occur pretty quickly after, and again, but I prefer perinatal, but if we're doing the postpartum within 4 to 6 weeks after birth, but often I will see that there were some symptoms before they actually gave birth. Duration, if we don't treat it, it can last several months. Persistent sadness, loss of interest. Again, it will impact your functioning. Therapy is going to be my first line. Medication always can always be helpful. But again, I'm going to talk about that. I really have that discussion with my clients. It's up to them. Postpartum anxiety, we've gone through that. Postpartum psychosis, I've kind of done a good blow by, but this is a good comparison chart as a handy dandy reference. Again, I talked about those differential diagnoses. What else could it be besides this? Could be bipolar, could be substances, could be a medical reason. It's important to rule out these other things before we start treatment because there are things we can give you that actually make the underlying treatment worse. Bipolar is kind of you go from the highs to the lows. If I think you're just on the lows, depression, and I give you an antidepressant, I could kick you up into mania. So I want to be able to do a really good, interview diagnosis about those things. My risk assessment, I'm always going to ask suicide. Everyone should be asked about that. Assess ideation. Do you have, any any thoughts of killing yourself or hurting yourself? If yes, do you have a plan? What's your intent? What are the means for those things? People need to learn to do a good one if you're a provider for those things. But I think it's also normalizing just the idea of anybody asking somebody they see in distress about this. Infanticide, again, harming the baby. Our number one thing is we have to ensure the safety of the infant because again, they can't protect themselves. Domestic violence, coercion is often a risk within some of this. That's where we're going to ask about that. I want to know, is this, unfortunately, sometimes within infanticide, it is not necessarily that they don't love the baby. They love the baby so much they don't want to put them they think in their delusional quality, think it would be better for the baby to not be in this environment that they can't escape. So what our plan would be, helping them escape that environment. create safety plans, who are their emergency contacts. But ultimately, if I think they are an imminent risk, an imminent danger to themselves, to others, to the baby, we're going to need an emergency evaluation. Hospitalization may be something we would have to consider. So again, those severity things, we just look at them. If it's mild, maybe just therapy. Therapy is wonderful. If it is kind of moderate to severe, using those screeners, psychotherapy, plus let's consider a med. Psychosis, we're going inpatient. Breastfeeding, we are going to try to choose a favorable medication for what is best for the mom within the symptoms. We will do a good bit, I will always do a good bit of education about that. What are the pros and the cons? But it is always client-led. It is what the mom wants. I also like to, and this is just on a personal level, where, I've talked about those things about like therapy, having a therapist, going to that, using medication. But sometimes those things are hard to find. They're hard to find therapy, and therapy can be expensive. So I always like to, I think everybody, every clinician, I think every person should have a way to develop their own personal strategies for coping. And these are some personal strategies that everybody should be able to use, not just pregnant moms, but strategies to manage our depression, to manage our anxieties, think about our long-term goals. I love crying it out. I'm a big fan of getting in the shower and crying it out and letting those tears fall. Therapy is wonderful, but we have to acknowledge some people cannot get hold of that as a resource. Friends, reaching out to family and friends, journaling. Journaling is a great way to kind of help you name your symptoms and improve your mood by prioritizing your problems. Big fan of that stuff. Challenging cognitive distortions. I'll show you, I have a little toolkit that I think everybody should use just to help people with these things. Deep breathing, square breathing, another great one. I'm a big fan of exercise, walking, anything that somebody can do. It doesn't have to be the gym. It can be, I have recommended for years, dance party. Some of my moms, I'm just like, you know what? Who do you like to listen to? What on YouTube? What on Spotify? I'm like, do a 10-minute dance party with your baby. Have the baby there and dance it out. Like, see, it's a great way to interact with your child. You're getting some exercise, you're deep breathing, you're bonding with the baby. Great thing to do. Healthy eating, outdoor activities, trying a new activity. These things not just limited to pregnant people or to moms. I think those are great for everybody. Psychotherapy, here's kind of the ones, the big options: CBT, cognitive behavioral therapy, IPT, behavioral activation. These are ones you're going to need a therapist for, somebody who is credentialed, which is different than support groups, which I think are wonderful too. But again, these are more trained professionals that can use very specific frameworks that they have expertise in. These will usually can be bi-weekly for 6 to 12 weeks, however long is needed. This is my first line option for any of my mood or anxiety disorders. And the good thing about post-pandemic, you can do it in person. We can have telehealth. You can do group formats. There's lots of Facebook pages devoted to maternal mental health, things like that. Group formats of people just getting together about these things. So that is an excellent option. It's usually my first line one. I will not bore anybody with these things. I do have a slide that if somebody is super interested in the medications, how to break them down. But again, our first line are going to be SSRIs. That generally fluoxetine, sertraline. Sertraline is pretty much the gold standard for pregnant people, because you can use it in pregnancy and you can use it well in breastfeeding. But the thing I'm going to always ask is, what have you taken in the past? Have you taken anything? No, I've never taken any medication. Okay, then I'll probably start with sertraline. But if they have taken something, I will probably start them on that one, depending on what it is. I always, again, ask, chemistry is different for everybody. We have great results for the majority of people, but people can be slightly different. So I'm going to go with what works for them. SSRIs are going to be what we do first line. You can use SNRIs, which has a norepinephrine component. We don't love those as much just because of some things that can happen in pregnancy. Though again, none of this is so bad. It used to be we would worry about like all these birth defects, all these things. What we see sometimes is that the risk for this is not as bad as we had thought. Our longitudinal studies are showing that No, but again, I talk about the risk versus benefit. I talk about with my patients kind of what would work for you. And we have really just good conversations about the true risk factors within this. And again, down here, I put it educate to place risks in perspective. When we talk about SSRIs, one of the things that they worry about is this persistent pulmonary hypertension. Well, persistent pulmonary hypertension happens in 2 out of 1,000 pregnancies, period. People on SSRIs, 2.9 times out of 1,000. So it's not that it happened 3 times, it's increased it by 0.9. So does that make sense? So I talk in my class about, oh no, it's not that 3 out of moms would have it. 2 of them were already probably going to have it. This increased your risk, but not by 3 times more, but by this. But again, and I talk about some of the side effects. The good part is a lot of these side effects that can happen are what we call transient. They are not forever. They go away pretty quickly for the child. But if you were already on an antidepressant when you got pregnant, mine is stay on it. I was like, your baby's already been used to it. So getting rid of it right now might not be a healthy thing at all. Safe during pregnancy, we will look at lactation. Again, I always talk about what is the benefit to the mom versus fetal exposure. We're going to start medications. We're going to monitor those effects for the baby, plan for delivery, plan for what's happening during pregnancy, plan for what happens after pregnancy. So those side effects to the infant, again, usually only 20, when they've had side effects to the baby, 22%, only 22% have been, have happened of the 25% of the time that it does. 22 has just been mild and transient, goes away after 1 or 2 days. 3% has been severe, but I talk with moms. I give them the option. And the most kind of the ones that we worry about, respiratory distress, which usually if your OBGYN knows, we may then do a different assessment, or we may then have the baby go to the NICU just for a few hours, just in case. But that again, that's up to the OBGYN, but we just don't see that much happening with these things in terms of high risk. They have proven to be relatively safe for pregnancy, for breastfeeding. And again, one of the things I don't like to do is switch meds. I said, oh, sertraline is great. It's kind of my favorite. But if they already were on another med, I'm not switching them to sertraline. I was like, stay on the med that you've been on, unless it's something that I'm like, oof, that is not my favorite. This is just for those pharmacology fiends that we may have in the room. And this is courtesy of, and this is one of my favorite resources, and we'll talk about it too. The Perinatal Mental Health, the Postpartum Support International has a certification course both on therapies and psychopharmacology, so the medications. So using that, they have broken some things down. I have cribbed this entire chart from them, and I refer to it all the time when I was prescribing, all the time, to sort of see like, okay, which ones of these. And what we saw again, this is probably sertraline. Zoloft is the fan favorite. Less of it carries over into the breast milk. And again, the side effects tends to be, again, short term, real short term, goes away pretty easily. The big thing I want to talk about though, is all of this stuff needs to be done through an integrated care model. It is not just one person. It is going to be obstetricians, midwives, primary care, psychiatrists, social workers, the entire pediatric team. All of that though, if this is a team, the quote unquote quarterback is going to be the client, is going to be the mom. So whatever, kind of, we will talk about certain preferences. I will educate well. But if that is what their care plan is or what they want to do, then that's what we're going to go with. But we're going to work with them to decide what medication decisions, what therapy decisions, safety planning, maybe about, again, what is this going to look like with breastfeeding. I've done this. This is completely adapted from, and thankfully, again, my work with the Nurse Family Partnership has a wealth of great resources that I was able to use. They do this depression, anxiety screening and referral decision aid. Very good for knowing when will you screen, what times during pregnancy, what times during infancy. If they are positive for moderate symptoms, if they're not, then we would just reevaluate next time they come in. If yes, so they're positive for, moderate to severe, we would look at, okay, what is the score? If the score is just mild, I might just document what we did, what some mild, what resources I give them, what supports. I will then be like in my head, I'll be like, and rescreen more often than normal. If it's pretty severe, one of the questions I will ask is, what's the imminent danger like? Are there thoughts of hurting themselves, thoughts of hurting the baby, thoughts of hurting others? That psychosis piece. If it's yes, that is an emergency referral. If it's no, then we can maybe do something outpatient, another referral that we can get them in with someone specialized. If we say, would you like to talk with a psychiatrist that specializes in this, or a therapist, or things like that? If they say yes, I will try to arrange for that to happen. Consider helping the client make the first call. If it's so bad that they are so depressed or so anxious, they may not be able to do it. So you can tell them, yeah, you should call and do this. I'm like, but we've just acknowledged they might not be able to. So help them make that call. It takes 2 minutes in the room with them. Um, Discuss the barriers to follow up. Discuss the barriers that they may have. Is transportation issue? Is these things an issue? Just saying, oh yeah, follow up with this person out in the community. It's hard. They're already, again, depressed, anxious. So take a little bit more time to help them navigate that. Provide coping strategies or resources. Plan for continued monitoring, continued rescreening. Even if you have said, oh, they see this psychiatrist, or oh, they see this person, I still ask, how's that going? How, do you feel it's been helpful? Because I look at them as a complete person. If I say, we'd like to give you a referral to this person, they say no, I'm going to document kind of why they didn't want to, because it's their choice, but I'm going to then maybe revisit. I will provide some personal coping strategies, some personal resources that I've put together to help them. I'm not just going to be like, well, if you don't take option A, there's no option B, C, or D. That's silly to do that to somebody. I will then assess what their family supports are, what their social supports are. I will use this thing called motivational interview to discuss options. Again, it is up to them, but I'd like to get to help understand what maybe the barriers are for them. And again, I'm going to continue to rescreen just to see where we are with what could be helpful. This, again, is my favorite, Postpartum Support International. If you know anybody, if you're interested in this is a wealth of resources. If you have somebody that you are worried about, or not even worried about, you're like, no, they're just pregnant. I want them to know this exists. They may have a wonderful pregnancy, never have any bits of this at all. But just in case, there are resources. There are resources for professionals. There is a complete hotline that you can call if you need to know what to prescribe, if you're unsure. To me, I'm like, there is almost no excuse for somebody not being able to treat a client in need when there are things like this out there. If you're just like, I'm not sure what to do, there are resources for you to get more sure to help them. Support, again, here's the thing about all these things. These are generally treatable. I don't want anybody to sit in the stigma of, if I have this, I'm going to be a terrible mom. If I have this, I'm not going, my baby is going to. No, this is usually related to a hormonal thing. This is related to an overwhelmingness of a whole new role. And again, you can be an and. You can love your baby and feel overwhelmed by your baby. You can love your baby and think, oh, my life looks different now. It's not a but situation. So I want to normalize those things for people because, again, there are resources. I want to engage not just the person, not just the mom, who their partner is, who their family is, bring in everybody in terms of the education, the supports. Address those social determinants of health. Again, what is the housing situation like? What is the food situation like? What is transportation? Sometimes some of this isn't depression. It is stress from externals they cannot control. There may be then other resources that we can give them to help with that. So again, those common barriers within that stigma. access to those mental health services, time constraints. So we're all barriers to getting the right supports. But we do, again, have solutions like telehealth, like an integrated approach for these things. Some additional resources, if you're going to go into this, or if you're looking into this, if you want to look at public policy for this, again, I said PSI, which is that Postpartum Support International, love it. It has great resources. Here's a couple of my favorite ones just in the Birmingham area. UAB has a perinatal mental health clinic. So again, that should be being able to refer somebody specifically to that. This is one I found at a general health fair that I really just love their vibe and have recommended to clients. Again, I get no money from them. I get no money from anybody for this stuff. But there is a Black Women's Mental Health Institute that will see clients, not just African American clients. They're just like, no, we'll see everybody. But we have gathered certain resources in our area, and we want to be able to help direct people to these. No, if you're going to go into this line of work, or even not even going into this, just helping people. What are the sliding scale therapists and clinics in your area? Sliding scale means most of the time they say, oh, it's going to be $100 an hour for you to see a therapist. That is a lot of money. Oftentimes, though, if you qualify, they can do a sliding scale that really looks at your income. Someone who has less income maybe pays $35, maybe does things like that. That can, if insurance covers it, that's awesome. But sometimes insurance doesn't cover things. So I want to know what resources are in my community for my other clients. If you go into this work, know what your hospital or facility protocols are. And if they don't have one, help make them. Help make them. And she's like, no, we don't get anybody that has postpartum psychosis. You've never had anybody that's come through here with postpartum psychosis? Mm-mm. I was like, that's not true. And we need to develop an algorithm for how to help treat that person. These are my personal resources that I just love. I've made this over the years. Again, here's a mental health hotline that I use. I'm a big fan of texting my clients, just not with my personal phone. You can have a Doxy phone to do this, but a lot of my clients, just like me, a visual works really well for me. So this is square breathing. This is how to challenge those negative thoughts that sometimes everybody has, but definitely if they pop up in pregnancy, or postpartum, we're less inclined to talk about them because we don't want people judging us as a bad mom. So I just kind of send this out all the time. There are some great apps on my work phone. I have a thing called client apps. I just send them these apps that I think have worked well. All these things during the pandemic. This is just a shout out. I talked about exercise. I would do virtual walks with my clients. We would Zoom together with my moms to talk about things. We would do therapy sessions that way to just see how they're going. So we did that stuff. They would be at whatever park or wherever they could be, and I would be often on Vulcan Trail, and we would walk together and just talk about these issues or talk about things. That was something that it was important to me to do. So I think just developing a resource toolkit on a personal level. So my take homes, again, early screening can save lives. Don't wait for symptoms to be worse. And don't wait, like if you are the person with these symptoms, please don't think you have to suffer in silence. Please don't think that like, I can't share this with anybody. Again, safety and suicidality are something we always assess, but I always think just because it is occurring now does not mean it occurs forever, but we need to get to a resource. We need to get help. I always involve my patient, my client in the decision making. That is on that they're the quarterback. It's not, I only know 30% of their lives, if that. So they are really the one that has to take this stuff. They know what works best for them. I'm going to individualize my treatment almost always. I'm going to plan for care and look at it again as a holistic model. Know your resources in your areas. And if there isn't a resource, make one. Within that, here are some of the references that I used for this. Any questions? And I know I have taken, a lot of time. I'm hoping for more stuff to be able to help with. So we have 7 minutes. I can go for as long as you guys need if we do have a lot of questions.
Please do not hesitate to take yourself off mute and ask Dr. Karmie a question. I think we got so much wonderful information. Man, I have notes. This has been incredibly enlightening. I've learned so much, and I'm sure plenty of people have plenty of questions. So feel free to take yourself off mute, drop your questions in the chat.
And it just doesn't have to be over this content. It can be over just anything. If you want to know like what the nurse family partnership does or what these things are, anything that interests you about coming to this session, it does not have to be limited to what I presented on. I'm happy to discuss anything.
I have a question about something that you presented on. First and foremost, I loved this presentation. Thank you so much for talking about this. It was incredibly interesting. But my question was in regards to earlier in your slides, you were talking about generalized anxiety disorders and how sometimes those symptoms show up prior to pregnancy. How do you all treat that if it's showing up prior to pregnancy?
So what I'm hoping is if they've been diagnosed, so what often happens is they just haven't been diagnosed. It gets worse in pregnancy, but if I do a little investigative backtracking, I'm like, oh, it's been there the whole time. But if they've had a diagnosis, there are certain medications that have been used in generalized anxiety disorder that we don't love in pregnancy. So then what my thing is, okay, we may have to wean you off those meds, but what are the other resources? I do think things like therapy, mine is you cannot cut somebody off from something that has worked for them without providing them lots of other alternatives for that stuff.
Okay, that makes sense. Thank you.
And Dr. Johnson, we've had a question as to whether or not you'd be willing to share your slides.
Sure.
Okay. Send them to Julie McDougall, me, and I will send them out when I send out the archived recording of the webinar or the seminar.
And I will say, just for a caveat with that, I probably did not do the best with putting my references and citations. Does that make so? As someone who works in academia, like I would be like, oh, I probably should have, used APA format for a lot of things. But if we can take that with a grain of salt, or you can, all this stuff is generally out there. You can Google it if you need a really good reference for some of this, if you're using it for the future. I will say all of it holds up. I'm not worried about that. I'm not worried about being it true, but I am just like, I'd want you to cite my source material, not me. Does that make sense?
Perfect. Thank you.
I've been reading a book recently. It's called Super Agers. So nutrition is on my mind. That's the chapter I just read. So I was just going to ask, have you seen or do you know if there's any evidence on certain diets or active activities that help prevent the psychosis anxiety or that help treat it?
I hate to say that when we get to the psychosis part, it is such a safety concern. I do think that people, there's so much going on with gut health in terms of vagus response and gut health and nutrition that is just such a wonderful area of study. It is not my forte or expertise, but I think that absolutely, I believe in those things. I believe in a whole body approach. So are there things that can be done to help with psychosis in terms of nutrition? My background tends to be in the acute. Does that, you know what I mean? And what I have seen in the acute adults, what I have seen is by the time they get to me, we need medication. We need medication. But I always think of health as spokes in a wheel, right? Medication is one spoke in that. Great nutrition is another, all those things. I do think that if someone says, I'm going to just do this alone, what I often ask my patients is, or my clients, I'm just like, okay, that's absolutely fine. When will you know it's time to use a medication? When will you know? And they're just like, well, if I start to do this, this, and this, if I start to have these thoughts, if I start to do this, and I'm like, okay, I can support you doing this as long as you know if it gets to be a safety issue, then we're going to have to discuss other options besides just this one. But I need you to be honest with me and to talk with me and be open with me in the same way I'm being open with you. And they're just like, okay, I can do that. I'm like, okay. And I'm like, and I'm going to check in with you. We're going to just ask these things. But if that's the route you want to try instead of medication first, I just need to know that you know when it'll be time for medication.
Gotcha.
Does that make sense?
It does. Thank you very much.
You're welcome.
I took lots of notes, by the way. Loved it.
Awesome.
I am curious, as a practitioner in the state of Alabama who works with low income populations or populations that might not have direct access to and or coverage of care, how have recent policy changes to coverage in Medicare services and changes to grants and community funding programs that cover things such as women's health and mental health for minority and marginalized populations impacted your work?
I am very, very fortunate being at the School of Nursing, UAB School of Nursing, which is wonderful and has great community partnerships and things. I worked with the Nurse Family Partnership, which is a national model, has been in existence for almost 50 years. And we are one of the first, I think we're the first school of nursing to have an NFP out of our School of Nursing, right? So we have piloted a lot of things for the national level. I'm the only in it, the NFP, which has some really great what they call facilitators that are based on some great psych mental health frameworks. Just wonderful stuff. But I'm the only one that has an embedded one. So that means I see clients. Most of the time, that's not something that anybody can has. All of that to say, that I anticipate a lot of changes, that I anticipate we will see a lot of clients not being able to get help that they need. I anticipate, especially in my other counties. So the NFP received an $8.1 million grant to expand throughout Alabama. So we're going to be in 37 counties. And there are two other NFPs in the state. So the NFP model should be covering the entire state in about 5 years, in about 3 years. But even then, that only is going to get so many clients. It's only going to get so many things. I just think, especially, so I think it will impact care. I think it will impact care. And I think that, fortunately, UAB is trying to do such a great job of finding ways to get good care to all of Alabama. The School of Nursing, School of Medicine, and our partners, public health, all, try to work together to come up with solutions for some of the new changes that have come.
I think I'm going to let that be the last question. And thank you, Dr. Johnson, for this presentation. If any of you had a question that you didn't get a chance to ask, when we're done with tonight's seminar, I'm going to send out an email to all the registrants that has a quick evaluation that we'd really appreciate you filling out. It's just probably 5 questions, but it helps us plan for future seminars. And you can reply to that email what your question is, and I'll make sure and pass that along to Dr. Johnson. If that's an answer that, is most appropriately sent just to you, we'll get that answered. If it's an answer that really would benefit everybody, then she can send me the answer and I can send out the question and the answer to everybody when I send out the link. So in an interest of taking good care of everybody's time this evening, Dr. Johnson, thank you so much for being with us. And I will send out the evaluation link in just a minute. And then when we have the archived recording available, I'll send that out too. And I hope you all have a wonderful evening.